So this lecture is about assessment of blood loss and blood transfusion. Since we are going to talk about blood loss and hemorrhagic shock, I would like to remind you what shock is. So what is shock? Shock is failure of the circulation to maintain adequate pressure flow relationships, causing reduction in tissue perfusion and nutritional insufficiency and metabolic abnormalities at cellular level. So in simple words, shock is where oxygen demand is not met with blood supply and oxygen supply to a particular tissue. So what are the different types of shocks? There are four main types: hypovolemic shock, cardiogenic shock, distributive shock, and obstructive shock. And today we will be talking about a type of hypovolemic shock, which is hemorrhagic shock or shock due to blood loss. So hypovolemic shock is a condition of inadequate organ perfusion caused by loss of intravascular volume, and generally this is an acute event. So hypovolemic shock can be caused by different causes. One common cause is hemorrhage or bleeding or blood loss, which is our topic today. Or it could be due to hyperthermia where the patient has excessive sweating, or could be due to persistent vomiting or severe diarrhea or uncompensated renal losses like in diabetes insipidus or hyposmolar diabetic coma. So in hemorrhagic shock, the characteristic thing is bleeding. So this bleeding could be from an isolated injury to a large blood vessel, or gastrointestinal bleeding, or non-traumatic vascular bleeding, like for an example rupture of an aortic aneurysm, or obstetric hemorrhage, example uterine atony, or another postpartum hemorrhage, or hemorrhage in the region of the ear, nose, throat area, for example due to vascular erosion. So this shock is triggered by the critical drop in circulating blood volume and massive loss of red blood cells intensifies the tissue hypoxia. So for convenience of describing, we are talking about different stages of hemorrhagic shock. So what are the different stages? So these stages are classified based on how much of blood or what is the volume of blood that is lost out of the total blood volume. So there are four stages: stage 1, 2, 3, 4, or we call it classes: class 1, 2, 3, 4, or mild, moderate, severe, and dying. So in mild hemorrhage or in class 1 hemorrhage, the victim or the patient has lost a blood volume which is less than 15% of the total blood volume. Here TBV stands for total blood volume. In class 2 bleeding or in moderate bleeding, blood loss is about 15 to 30% of the total blood volume. In class 3, blood loss is about 30 to 40% of the total blood volume. In class 4, where a patient is supposed to be in dying hemorrhagic shock, blood loss is more than 40% of the total blood volume. So we'll look at mild bleeding first, or stage 1 of hemorrhagic shock, where the patient has lost a blood volume which is less than 15% of the total blood volume. Now the total blood volume of an average person is about 5 liters or 5000 milliliters. Therefore 15% of total blood volume is 750 milliliters. So therefore in this patient the blood loss is roughly less than 15% of the total blood volume, which is less than 750 milliliters. And in this stage the damage, the injury that is happening to the body is being compensated by vasoconstriction alone, and still the patient's pulse, blood pressure, and central venous pressure may be normal. In moderate bleeding or stage 2 blood loss, the blood loss is about 15 to 30% of the total blood volume, which is about roughly 750 to 1500 milliliters of blood loss. And by this time, the filling pressures to the heart are low, therefore central venous pressure is also low. Pulse volume will be low and the patient will be tachycardic. Since the circulating blood volume is low, the patient is trying to manage with an increased heart rate. That's why the patient gets a tachycardia. And the peripheries of the patient would be cold and pale, and diastolic blood pressure may even be increased more than normal due to severe vasoconstriction, and still the systolic blood pressure may be normal. So in a stage 2 hemorrhagic shock patient, so there will still be a pulse. The patient may be tachycardic and having a lower volume of pulse. So this stage of shock, the stage 1 and 2, we still call compensated shock, because the blood pressure may be still normal and the patient is trying his best to compensate for the blood loss that has happened. So certain parameters like the blood pressure may still be normal. So now we are coming to stage 3 blood loss, so severe blood loss, where the patient has lost a blood volume of roughly 30 to 40% of his total blood volume, which is about 1500 to 2000 milliliters. And there's a lot of compensatory work going on, so which is partly compensated by selective vasoconstriction of vessels that are supplying the skin, muscles of the limbs, and splanchnic vessels like the blood supply to liver, kidney, and gut. All these will have severe vasoconstriction. And there's preferential perfusion to the heart and the brain. So the body is trying to perfuse the heart and the brain at the cost of cutting off blood supply to the liver, kidney, gut, muscles, and the skin. Now, by this stage, the patient's blood pressure is low, especially the systolic blood pressure is low, but still it is maintained with increased systemic vascular resistance, and diastolic blood pressure may be still high, and there's reduced pulse pressure. Central venous pressure will be quite low, pulse volume will be very low, there will be severe tachycardia, urine output will be low. Patient may be confused because the blood pressure, blood supply to the brain is severely affected by now. Patient may be cold and pale. Capillary refilling time is reduced now. So in this photograph, you see a patient who has died due to bleeding or who is dying due to bleeding, where you can see that the patient is extremely pale because he has lost so much of blood. Okay, so we went through the 4 stages of blood loss. Now let's see what are the type of reactions that are happening in a person's body who is bleeding, who is in hemorrhagic shock, to compensate for these blood losses. So in the early phases of hemorrhagic shock, which we call compensated shock, there's acute compensation happening within minutes, and there are certain changes that are happening within hours, and another set of changes would happen over a few days. So what are the things that are going to happen immediately? So within minutes, there's going to be an acute compensation by reflex sympathetic stimulation via baroreceptors, which are located in the carotid sinus and aortic arch. So there will be reduced stretching of baroreceptors due to low pressure, and there will be chemoreceptor, peripheral chemoreceptor stimulation, which are in carotid and aortic bodies by hypoxia. And there will be stimulation of central chemoreceptors in medulla of the brain by low pH and carbon dioxide and high carbon dioxide. And there will be more changes happening in compensated shock, where there will be an attempt at restoring the lost fluid volume within hours. And over the next a couple of days, there will be slower regeneration of blood cells and proteins to compensate for the losses. So to discuss the reactions or compensatory changes that are happening in a victim who is bleeding in detail. So one of the first things to happen at a very early stage of hemorrhagic shock is autotransfusion, where the patient will be transfused with blood, patient's own blood. So where does this blood coming from? We know 70% of blood volume of the patient is in venous capacitance vessels. Therefore, by post-capillary venoconstriction of venous capacitance vessels, like in skin, splanchnics, and large veins, lungs, this autotransfusion can compensate for about 10% of blood loss without a fall in blood pressure of the patient. And there will be redistribution, as we mentioned earlier. There will be preferential circulation of blood to brain and the heart by cutting off blood supply to the skin, muscles, and splanchnics. So there will be arterial constriction in skin, muscles, and splanchnics, like in kidney, liver, and gastrointestinal tract. And there will be a preferential circulation to the brain and the heart. And another important thing that is happening is autoinotropism and autochronotropism. So in inotropism or positive inotropism, cardiac contractility will be increased, and in positive chronotropism, the heart rate will be increased. There are more reactions happening. So there will be auto-infusion from interstitial fluid into the intravascular compartment. So auto-infusion it's like infusing saline to a patient. So interstitial fluid will be mobilized from the interstitial compartment into the intravascular compartment. So this can even pump fluids like, say, to a maximum of about 1 liter per hour. And there will be auto-infusion from intracellular compartment into the intravascular compartment. So from the intracellular compartment to the interstitial compartment, from there to the intravascular compartment. So during the compensated shock, there are some more changes happening. So another thing is water retention, which is called the renal defense. So which will happen over the next 1 hour or so. So blood will be shunted via medulla of the kidney, bypassing the cortical glomeruli. Therefore, afferent arteriolar blood pressure would fall, activating renin-angiotensin system. And we know angiotensin itself is a powerful vasoconstrictor, which will act immediately, and it will stimulate aldosterone, which can lead to sodium and water retention. And ADH will also be released due to low pressure in baroreceptors. And ADH will also retain water. So lost blood volume will be restored by auto-transfusion and auto-infusion and sodium and water retention. So auto-infusion would be from interstitial fluid compartment initially, and then from intracellular compartment as well. And there will be sodium and water retention by antidiuretic hormone and aldosterone. So as shock progresses, heart rate will rise further, venous return will drop further. In the process, central venous pressure and the right atrial pressure will also drop, and the cardiac output will fall secondary to that. And the blood pressure will fall when the blood loss is more than 30% of the total blood volume, and especially when the lost blood volume is in the range of 40 to 50% of the total blood volume, blood pressure will be unrecordable. So this chart shows a summary of what happens in the body when a victim is undergoing different stages of hemorrhagic shock, class 1, 2, class 3 and class 4 of hemorrhagic shock, how pulse rate, systolic blood pressure, diastolic blood pressure, pulse volume, capillary refilling, etc. change as the patient progresses through different stages of hemorrhagic shock. Okay, let's say we have got an unfortunate patient who is bleeding in hemorrhagic shock, and what should we do? So successful management of a bleeding patient requires prompt action in detecting blood loss and assessment of the blood loss. And we need to control bleeding immediately. So apply pressure on the bleeding area, or apply a tourniquet, or try to localize the artery or vein which is bleeding and catch that bleeding artery with an artery forceps and control bleeding, or diatomize or coagulate the bleeding vessels. And we need to resuscitate the patient immediately by giving intravenous fluids, or if necessary blood, warming up the patient a little, giving oxygen, elevating the legs of the patient, trying to force stagnating blood in legs to the main circulation, and controlling airway while giving oxygen. And if the patient reaches the irreversible state of shock, or irreversible or decompensated shock, well, there will be myocardial depression, microcirculatory stagnation, there will be cellular hypoxia, acidosis, toxemia, there will be lysis of cell membranes, and toxins and metabolites from inside cells will be leaking out. They will cause further vasodilatation and myocardial depression. There will be loss of fluids, and there will be activation of coagulation and leading to disseminated intravascular coagulation, ARDS-like picture in the lungs. There will be bacteremia and failure of energy mechanisms, finally leading to multi-organ failure, eventually death of the patient. Right, so in a nutshell, when we manage a patient who is in hemorrhagic shock, we need to control bleeding as early as possible and start rapid fluid resuscitation immediately, trying to re-expand the fluid compartments with intravenous fluids, crystalloids or colloids, whatever that is available, improve microvascular flow, try to redistribute the cardiac output, use iron ropes, and correct effects that happen due to underperfusion like low pH, hypoxia, and electrolyte imbalances. So in a patient who has bled a lot, rapid restoration of circulatory volume is needed to prevent further vasoconstriction, which is very harmful to the patient, and to prevent increased viscosity of blood and to prevent stagnant hypoxia, all of which can cause irreversible changes in the microcirculation, leading to multi-organ failure and finally death. So as I mentioned earlier, the body will try to compensate for the lost fluid by retaining some fluids by activating renin-angiotensin aldosterone ADH system. Meanwhile, we as medical people need to intervene and try and start fluid resuscitation by infusing some intravenous fluids to the patient. So if the patient has lost only a small amount of fluids, we probably can get away by infusing some intravenous crystalloid solutions. But if the patient has lost a lot of blood, if the bleeding has been very severe, then we need to infuse colloids. So these colloids could be synthetic colloids or natural colloids like blood and blood products. So what is special about colloids that is useful in a patient who has bled, who has had hemorrhagic shock? So colloids contain solutes with high molecular weights, and they do not cross capillary membrane easily once infused, and once inside the intravascular volume, they would not cross capillary membrane easily and would not easily leak out of blood vessels. Therefore, they will increase the plasma osmotic pressure, and they will draw water from interstitial fluids and intracellular fluid into the vascular compartment. And therefore, colloids have a longer half-life in plasma, maybe 3 to 6 hours, whereas the half-life in the intravascular compartment of an infused crystalloid may be only 20 to 120 minutes. Therefore, colloids are considered as effective plasma volume expanders, and general rule, if we are trying to compensate by or we are trying to restore the lost blood volume by infusing a colloid, we can infuse colloids at a ratio of 1 to 1. So if a patient has lost a blood volume of 1 liter, infusing colloids of 1 liter should be fine. Whereas if the patient has lost 1 liter of blood, and if we have only crystalloids, if we do not have colloids, we might have to infuse at a rate of 1 to 3, where we will be giving or we will be infusing a volume that is of 3 times of the blood that was lost. So what are the different types of colloids we have to be infused in a patient who has bled? So we have natural colloids like blood and blood products, and when we transfuse blood and blood products, we have to bear in our mind that there's a possibility of the patient having complications due to transfusion. And then we have synthetic colloids like gelatin solutions, dextran and albumin. Gelatin solutions can cause anaphylaxis, so severe allergic reactions, and they are expensive. Dextrans again are expensive and can interfere with blood cross matching. They have antithrombotic and anticoagulant effects, and they can also lead to allergic reactions, including anaphylaxis. And albumin solutions again are very expensive, and salt-free solutions are better than ordinary albumin solutions. Right, we will talk a few words about blood transfusion. You have a separate lecture on blood and blood products. So here I'll be dealing largely about clinical aspects of blood transfusion. Now, human red cell membranes are estimated to contain at least about 300 different antigenic determinants. And we have at least about 20 blood group antigen systems, out of which largely the ABO and rhesus systems are important for blood transfusions. Second thing we should know is individuals often produce antibodies or alloantibodies to the alleles they lack within each system. And it is these antibodies that are responsible for the most serious reactions to blood transfusions. So these antibodies may occur naturally or in response to sensitization following a previous blood transfusion or pregnancy. So when we look at the ABO and rhesus blood group systems, under ABO system we have 4 main blood groups, which are AB, A, B and O. And blood group AB has antigens of both A and B and no antibodies. Blood group A has A antigen and B antibodies. Blood group B has B antigen and A antibodies, and blood group O has no antigens and both A and B antibodies. Therefore, a blood group AB can receive a patient who has the blood group AB can receive blood from any other group AB, A, B, O, O. Hence it is called universal recipient. On the other hand, a person with blood group O, that person has no antigens and can donate blood to any group AB, A, B, O, O. on the other hand, can receive blood only from a person with blood group O. Hence, a person with blood group O can donate blood to a patient with any other blood group. Hence, blood group O is called the universal donor. Then, depending on the fact whether the patients have the rhesus factor or not in their blood, again, all blood groups, all ABO system blood groups can be subdivided into rhesus positive and rhesus negative blood. Patients who have the rhesus factor are called rhesus positive blood, and the blood groups that do not have the rhesus factor is called rhesus negative blood. So patients with rhesus positive blood can receive blood from both rhesus positive and rhesus negative blood. And patients with rhesus negative blood can receive blood only from donors with rhesus negative blood. Now, in addition to the ABO and rhesus system, there are many other minor blood group systems which are of less importance as far as blood transfusion related reactions are concerned. Lewis, P, MNS, Kidd, Kell, Duffy, Sid, and Cartwright are few to be mentioned. Compatibility testing is essential before routine blood transfusions. So the purpose of a compatibility testing is to predict and prevent antigen-antibody reactions that can occur after a blood transfusion or during a blood transfusion. So the three main things that are done in a compatibility testing is, firstly, we do a ABO and rhesus testing to verify the patient's ABO and rhesus blood group. And as I mentioned earlier, it's the ABO and rhesus system that are responsible for most severe allergic reactions that can occur during or after a blood transfusion. Then there's a cross-matching, and a cross-matching mimics a blood transfusion where donors' red cells are mixed with recipient's serum, and with the cross-matching you can predict whether there's a possibility of an incompatibility that can happen. Thirdly, there's an antibody screening to check for presence of antibodies that are commonly associated with non-ABO reactions. So after a storage time of about 1 to 3 days, 24 to 72 hours, red cells have a reduced capacity to release oxygen to tissues. So if a patient needs a heavy blood transfusion, a massive blood transfusion, better to transfuse blood which is less than, say, 7 days old. Right, so both during sampling of blood and transfusing blood, you have to be very careful to establish identity of the patient. So you have to check patient's identity with the patient and patient's notes and the wristband or whatever the identification tag that the patient is wearing. So during sampling procedure, you can ask the patient to tell his name, in fact the full name and date of birth. Check this information against the patient's identity wristband or the band that he's wearing on his clothes. Next thing is to check the patient's identity or the information given in the wristband against documentation. Again, check the patient's first name, surname, full name, date of birth, and the hospital registration number. And to avoid errors in identification, to avoid confusion, better to draw blood from a single patient at a time. Bleed only one patient at a time, and do not use pre-labeled tubes. So draw blood, put it into the sampling tube, and then label it with the patient's name, date of birth, and the hospital registration number. So what information do we need when we send a venous blood sample to the blood bank? We need to put the patient's full name, date of birth, hospital registration number, gender, whether the patient is male or female, date, and the signature of the person who has drawn the sample of blood. Stored blood is cold because blood is stored at a temperature of at about 1 to 6 degrees centigrade, roughly at 4 degrees centigrade. And when you look at a patient who is undergoing a surgery, patient is already losing heat. because the patient's tissues and body cavities are exposed to low temperatures of the operating theatre. Operating theatre, as you all know, is air conditioned and the temperature is at about 16 to 18 degrees centigrade, or maximum it will be 20, 21, 22. And because the patient's body temperature is 37 degrees centigrade, there's a huge temperature difference. So the patient is losing heat anyway due to that large temperature difference also by radiation. Then on top of that, patient is receiving cold anesthetic gases and cold oxygen, and patient's thermoregulatory mechanisms are paralyzed due to anesthesia. Hence, the patient is at risk of becoming hypothermic. So, hypothermia can lead to cardiac arrhythmias, delayed blood clotting, hypotension, and many other problems. Now, on top of that, if you transfuse blood which was stored at 4 degrees centigrade, take it out from the blood bank, bring it to the operating theatre, and you straight away transfuse that blood. You are exposing the patient to a grave risk where the patient can become severely hypothermic. Therefore, it is always advisable to transfuse blood which is warm. So, ideally, we should use a blood warmer, not only for patients who are undergoing surgeries in the operating theatre, but for all other patients who are even in the wards and intensive care units. So, a patient has to be observed, monitored during a blood transfusion and soon after a blood transfusion, because there's a possibility of a patient developing adverse reactions for a blood transfusion, like allergic reactions, including an anaphylactic reaction, things like getting fluid overloaded due to blood. Patient can go into heart failure, can become hyperkalemic. Therefore, monitoring a patient during and soon after a transfusion is essential. So before starting transfusion, establish baseline observations of the patient. So record vital parameters like pulse rate and volume, blood pressure, temperature, and respiratory rate before starting the transfusion. Then when you start the transfusion, start it slowly, transfuse blood slowly over the first 15 or so minutes to see whether the patient is developing any reactions, and observe the patient at least every 5 minutes during the first 15 minutes of transfusion, and make notes of your observations. Thereafter also, during the transfusion and soon after transfusion, you should continue to monitor vital parameters of the patient. And this monitoring has to be done more frequently if the patient is say unwell or unconscious, like a patient who is in the ICU, or if the patient is a very feeble patient, weak patient, or the patient is an elderly or child. So before starting the blood transfusion, ensure that the cannula, what I have mentioned here as Venflon, is the most commonly used brand of cannula, whether it is secure and there are no signs of inflammation around the cannula. Give the patient the call bell, or make some arrangements for the patient to call you in case of a difficulty. And the patient should remain in a clinical area where observation is possible, and review the patient's fluid balance and medication before starting transfusion and at the end of transfusion also. Right, now you are about to start the blood transfusion, so you have to bear in your mind that there's always a possibility of you giving a wrong blood to a wrong patient. So check the patient's identity before starting the transfusion. So you should be having personal protective equipment like a pair of gloves before opening the blood bag, and a completed prescription chart, observation chart, and a sterile giving set should be available. So first of all, you should check the patient's identity. So ask for the patient's full name, date of birth, and check this information with the patient's identity wristband or the label or the tag the patient is wearing on the patient's clothes. Okay, now you have verified patient's identity. Now check the blood bag that you have got from the blood bank is the correct blood bag. So check the patient's, the donor's name, date of collection of the blood packet, and the date of expiry, the blood group, with the details mentioned in the chit that has been sent by the blood bank. Then also check the patient's identity together with the chit that has been sent by the blood bank with the patient's bedhead ticket or the patient's notes. If the patient develops any adverse reactions during blood transfusion, the transfusion has to be stopped immediately. And as a doctor, you should go to the patient immediately and talk to the patient and assess the patient's vital parameters. And after stopping the blood transfusion, that has to be informed to the blood bank. So check whether the blood component matches with the patient's details and remove the blood transfusion set that has been there together with the blood bag and start infusion of a normal saline drip. Send the discontinued blood unit with the giving set to the blood bank after capping it properly, and this should be documented in the patient's notes and complete a incident blood form or blood transfusion reaction form. Right, once blood is harvested from a donor, it undergoes processing, and during this processing different blood components are separated like packed red cells, platelet rich plasma, fresh frozen plasma, cryoprecipitate, etc. Then depending on the requirement, we can transfuse different types of blood products for these patients. So what we transfuse could be fresh whole blood, or could be stored blood, could be whole blood or a fraction of blood, and it could be autologous blood transfusion or blood from a different donor. Like for an instance, a patient who has had a blood loss during surgery might need red cells and a volume as well. So that patient would benefit from whole blood. Whereas another patient, like a patient who is very anemic and in compensated congestive heart failure or very hypoxic, may need only whole blood or red cell concentrates. So the dose for a red cell concentrate would be 10 milliliters per kilogram body weight, and generally blood transfusion has to be completed over 1 hour, because longer you keep blood outside storage conditions, higher the chances of that blood being contaminated with various bacteria. Again, fresh frozen plasma will be useful for a patient who has a coagulation factor deficiency. Let's say a patient who has undergone massive transfusion, who has had red cell transfusions but now needing clotting factors, and another patient who is thrombocytopenic or whose platelet count is normal but functions of platelets have been reduced, for an example due to using antiplatelet drugs, would benefit from a platelet transfusion. Cryoprecipitate will be useful for a patient with fibrinogen deficiency, and granulocyte transfusion would be indicated for a patient in severe neutropenia. There are many complications associated with blood transfusions. Those can be largely subdivided into acute and delayed complications. Both these groups can again be subdivided into immunologically mediated and non-immunologically mediated reactions. Examples for acute immunologically mediated reactions are allergic reactions, febrile hemolytic transfusion reactions and non-hemolytic transfusion reactions, anaphylactic reactions, and TRALI or transfusion related acute lung injury. There can be non-immunologically based reactions like bacterial contamination or sepsis, transfusion associated circulatory overload, clotting abnormalities like dilution, coagulopathy, dilution, thrombocytopenia, then metabolic complications like citrate toxicity, hyperkalemia, hypocalcemia, hypothermia, acidosis, reduced 2,3-DPG. Then under delayed or long-term complications, there can be immunologically mediated ones like delayed hemolytic transfusion reactions, alloimmunization, graft versus host disease, post-transfusion purpura. Then under non-immunologically mediated long-term complications, there can be infections like viral infections like HIV, hepatitis B virus, C virus, HTLV, rickettsial infections, then parasitic infections like malaria. There can be thrombophlebitis and iron overload. Thank you.